Hello and welcome back to the Neurotransmitters. We are today continuing our Chief Concerns series. So for all of our primary care and other non-neurology colleagues, hopefully this one goes out to you. I am joined, as always, by the relentless educator, Dr. Galina Geigman. Thank you again for joining me on this adventure. And our special guest for today, Dr. Marcus Pinto, an adult neurologist and peripheral nerve and neuromuscular specialist at the Mayo Clinic in Rochester, Minnesota. Thank you so much for joining us today.
It's my honor. Thank you, Michael, and thank you, Galina, for inviting me.
So, Galina, go ahead and kick us off. What are we starting up on today?
Yeah, well, thanks again, Michael, for letting me join as your co-conspirator in this special series. I'm super excited for today's topic, which is kind of the patient with a new sensory change. And we're actually going to dive into, I think, the history and kind of how patients come in. But Marcus, I just wanted to start with, I know you're a specialist, but how often do you get this referral from primary care doctors? And I can't tell you enough that in my clinic, I often hear the referral is actually written neuropathy, and the patient comes in, they say, I'm here for my neuropathy. And, they use this term. So I'm curious, how often are you seeing this? And when you kind of actually drill down to what patients complain of, how is it, what are the symptoms, I guess, in a way that really bring people in for this chief concern?
Yeah. So, that's a very common, I think. And also I do EMG. So, it's a very common indication for EMG, the question of neuropathy, and I completely agree with you. I think a lot of times patients start to feel abnormal sensory changes, in their body, and they always attribute to neuropathy right away. And they usually come to you saying they do have a neuropathy. And that's what Google tells them as well, right? If you type, I think, new onset paresthesias or new onset numbness and tingling in the feet, that Google will tell you. So I think the most important thing when someone is complaining to you about new numbness or new tingling, so I usually tell my residents, and my fellows to not, because the definitions of numbness and tingling, they're a little bit. So the textbook definition would be that numbness is the kind of a novocaine type of sensation that you feel, like when your dentist, for example, kind of numbs you for anesthesia. And the tingling will be the tingling, prickling sensation. But it's very hard for the patient to differentiate that, and also differentiate numbness, which also by textbook definition, numbness and tingling are both positive symptoms. And the decreased sensation or lack of sensation, it's a negative symptom, So usually patients do not complain much about that. When we talk about kind of a specificity of symptoms, so the decreased sensation, the lack of sensation, and usually they will tell you that they can't feel the temperature in the soles of their feet when they walk in the beach, or they live in Minnesota, like I live. When they go outside, kind of a bare foot, in the winter, they can't feel that the floor is very cold or the snow. So, whenever the patient tell you a negative symptom, that is much more specific of neuropathy and objective that they may be having a neuropathy. But that's not the most common. So then, life is complicated. So the numbness and tingling, as I told you, they're positive symptoms, and they can happen from neuropathy, from venous insufficiency, from musculoskeletal issues, just you staying on the same position for a long time. So there are so many other causes other than neuropathy, that I think people should be aware of. And usually what is important to me is not only that they feel it, but where they feel, and is it constant or not? So, and where they feel. So it's because if you have any numbness or tingling or any sensory changes in your legs, but not in your feet, that's very unlikely to be a neuropathy. If you have sensory changes in your hands, that you wake up at night, you shake your hand and it improves, which is most likely carpal tunnel syndrome. If you have, for example, sensory changes in your lateral thigh, and you have an abnormal BMI, you have you're overweight or obese, or you do a lot of For example, kind of you wear a lot of tight clothing or you work in construction, and then you have sensory change in your lateral thigh. This might be myalgia parastatica. So the location of the symptoms is so important. You have, for example, cervical spine disease, and then you have intermittent shooting sensory changes to your arms. So the classic sensory changes of peripheral neuropathy, which is a process that is worse in the feet than in the legs and thighs, and also worse in the hands than in your shoulders and forearms. So you must have a distal, which means hand and feet symptoms. If they are constant or not, that's a very important question. Usually, intermittent sensory changes are what you call benign, and benign means can be anything else, okay? Can be musculoskeletal, can be vein, can be any other cause other than neuropathy. So neuropathy usually causes constant symptoms. So whenever someone tells you that they have constant numbness and tingling in their feet, that increases the likelihood, it's not diagnostic at all, okay? It's not that specific, like, for example, the decreased sensation in your entire foot when you walk in the beach again. But that makes it more likely than if they're intermittent. And I just posted on X, doing a little bit of also here of advertising also my X account. You guys can follow me there, and I post neuropathy stuff there. And usually these neuropathy posts come from the clinic. I don't have an agenda. I don't have like you guys very organized. You have like schedule and series of posts. I don't have that.
Marcus, what's your handle for folks to find you there?
Yeah, so it's Marcus, Marcus V Pinto, like the pinto bean. So Pinto, okay? Yeah, so Marcus V Pinto. You can find me there. So I even posted there because in clinic, I was teaching a fellow this, and someone else heard, say, oh, good, I never heard about it. Because I learned this from one of my faculty in my professional fellowship, which is, so I always ask the patients, if they come for sensory changes, I always ask them in the office to close their eyes. And they close their eye. And make them close their eyes. If they don't close, they close, and then they close. And I say, okay, so now try to concentrate in your own body, okay? And I give them like 2-3 seconds. And then I say, okay, do you feel anything abnormal in your feet or your legs? I ask them that. Because why I say that? Because intermittent paresthesias can also be neuropathy. Because you all know that our brain is very powerful. Our brain has the power to block any type of sensory kind of input. That's why people go to war, they lose a limb, and they keep running. They keep fighting. So like if you, Michael, and I, or you, Galina, if you lose an arm at our office, I'm sure we're going to pass out on the floor, gonna be a cold blue and all that. So, but your brain is able to block signals, and that's why also that any kind of a patient that has a sensory complaint or pain or any sort of sensory change, if they go on vacation, the symptoms get better. But going back to the question, so then I ask them to close their eyes, concentrate the body, and say, hey, do you feel anything abnormal in your feet? And if they usually say no, I've never studied this, okay? This is just kind of historic neurology education, okay? It would be interesting, I think, even someone will say, oh, you should study this. But I'm interested to study this prospectively. But if you do that and they say no, that they don't feel anything abnormal in their feet, it's unlikely that they have a sensory neuropathy. Okay, so I always do that with everyone. And then people can do that in the primary care doctor office anywhere. You can just ask that. And if they say that when they close their eyes, they concentrate their body, and they feel that they have abnormal sensation in their feet, so that increases, again, the likelihood they may have a neuropathy.
Interesting. I'll have to try that one out.
Yeah. Tell me what you think.
Now, that kind of raises a question, because we were talking about positive, negative symptoms. And, one of I think the most, other than the typical ones like balance problems, a lot of people are describing pain of some character or another. What role does pain have in your diagnostic assessment? Or does it factor in at all, or comes in at the end when we talk about treatment?
Yeah, no, that's a very good question, because it's usually, what the patient comes for, because usually the negative symptoms, the balance and the lack of sensation, they usually don't complain about it. So usually only when it gets more severe, like, for example, you all know in neurology, like you see a patient, for example, with negative motor symptom, if they don't have any positive sensory symptom like pain or paresthesia, they may only show up to your office when they are significantly impaired and disabled, because they just, the symptoms, they are not like stroke-like, any kind of a chronic symptom, they come slowly progressive, and then it's very hard for the patient to know exactly when it started. But when there is pain, it's much easier because it's painful. They will always be reminded of that. So the pain, I also use positive sensory symptom, paresthesias and tingling, numbness and tingling, and usually if the pain is constant, not constant, the same kind of pattern. The neuropathic pain can be described by the patient as essentially anything other than achy pain. So very rarely true neuropathic pain is achy. Usually achy is musculoskeletal or any other kind, but very rarely is neuropathic. However, it's possible, so be careful because patients, we all know, and it's not easy to describe how you feel. And for many people, many people, like my wife, for example, she has migraines and she took like 10 years to tell me her migraine was throbbing. She couldn't describe to me the throbbing nature of her migraine. She's a physician, so just because, life is much harder than what we read in the textbook. So I think keep an open-minded, but usually description will be of a burning and a shocking, like a zinga. Some patients describe as kind of a knife stabbing sometimes. But and it is usually will affect not only one location. That's an important thing. So where do you feel the pain? So usually going to be of a kind of a sock or gloves distribution, for the pain, or sometimes a distribution of a specific nerve. But very rarely it will be at a focal spot. So if someone say, "Hey, I have a focal spot in my foot that hurts like hell," that's usually not neuropathy. Foot arthritis, for example. And I usually what I do also, we haven't talked about exam yet, but as a neuropathy doctor, patients always apologize to me about their feet. They say, "Oh, no, I'm a neuropathy doctor. I see the ugliest feet in the world." Because I go to their feet and I palpate their feet. I press the balls of their foot. I press, the kind of, because, for example, the common thing, and some people think is neuropathy, which is whenever people have plantar fasciitis. So more common in runners, people who are on their feet a lot. And there are two things important for plantar fasciitis. One, so you ask them, when in the day your pain is the worst? Because plantar fasciitis is when they step out of bed. And the other thing is to go to their foot and press the middle of their foot. Just go, say, "Hey, I'm going to press your foot here, see if then you go and you press the foot to see that tenderness there, because if plantar fasciitis they may have, but also arthritis of the metatarsal joints and all that is the same thing. You have to palpate. Some people some people have like, we don't know why, but some people have not neuropathy, but they have a very kind of a small fat pad in their feet, and their feet like usually plainness, and also flat foot, and they have no protection, of the bones, and they develop more commonly arthritis of the feet and all that. But again, usually the neuropathic pain will be usually worse at night. Usually will also worse when they walk, worse when they keep standing. If someone tells you, "Oh, I have pain in my feet," and then at night, and then I stand up and walk, and that make it better. It's weird. So maybe, okay, think about sometimes, rarely, but sometimes we see in the office people showing up with sensory changes and they have restless leg syndrome, which you all know can be associated with neuropathy, but sometimes it's just RLS. So using, I think, a good history and a good exam helps a lot seeing patients with neuropathy.
Great points.
Yeah, I love the discussion about how difficult it is to describe the symptoms. I feel like I'm keeping like a mental log of just the interesting things people say. Like they'll say, "My feet are like cinder blocks," or "I feel like I'm wearing socks all the time," or they'll say, "Oh, don't put bed sheets on my feet, don't touch my feet." And also the one I hear quite a lot is like, "My legs are heavy or they're weak." And so I think as a neurologist, you have to take, with a grain of salt, the description and then verify with the exam. But I often hear people complain of weakness when they really mean like a sensory ataxia, for example, that makes it difficult to, grip things or to find the right place of when they're walking. And we'll definitely get to the exam. But I was wondering, actually, Marcus, do you ask about autonomic symptoms? I feel like this is something I think about sometimes on the history, especially when I'm suspecting small fiber neuropathy. And I want to maybe get a little bit more information because, as we know on exam, that may not necessarily be so revealing. Could you talk a little bit about that? And would you ask that? And if so, how do you ask about that?
Yeah, no, I always ask. Yeah. So the review of systems of neuropathy that I usually do, I always ask about autonomic symptoms. I always ask about bulbar symptoms. I always ask about fever, night sweats. And I always ask about weight loss. And I always ask about skin changes, rashes. Yeah, I always ask about that. Just 5. So all my fellows, they need to come with, all just questions answered. And just questions asked and give me the answers when I staff them. So, but then going back to autonomic. So autonomic symptoms are tricky. Okay. Why? Because they are sensitive, but they are not specific of true autonomic dysfunction. So, for example, someone can tell you that they have dry eyes and dry mouth, and that can be, Sjogren's syndrome, or can be if they take like duloxetine or they take something, I don't know. So I think I always ask, but I think the most significant ones, the most specific ones are gastroparesis. So whenever they tell you, say, hey doc, especially when they spontaneously tell you. I think also when they complain without you asking, always specificity, I think is increased. Because a lot of times, right, Galina, you probably see that as well, that patients, they are nice people and they want to be nice to their doctors. Usually they think that saying yes to our questions, they're going to satisfy us. And then they say yes. So anyway, this is what I see a lot of times. The patients, they try to be nice to their doctors and they don't know that, they really should be very thoughtful when answering the question. But going back to the symptoms, so gastroparesis, so whenever they tell you that they used to eat a normal full meal, now they can eat like only like 10% of it. They have a lot of, they feel bloated all the time when they eat just a little bit. And usually ask them for examples, or whenever they can give you examples of things they have eaten. Like, hey, I ate like half an apple for lunch and I was completely full. Or I ate like a full meal at X restaurant and then I was throwing up, So gastroparesis is very specific with early society, what you're talking about, and also easy bloating. And I also think that orthostatic hypotension is very specific. And so whenever I ask, hey, do you feel lightheaded when you stand up? Like all of us, right? So if you go to the beach and then you stay there, for like 5 hours and you take no liquids and you stand up, you're going to feel lightheaded. Maybe you even pass out. So it's always important for you to ask the patient what situation and how often that happens. Because when it's true autonomic dysfunction, they will tell you that I stand up, I have to hold myself. A lot of times I feel I'm going to pass out. And then after like 30 seconds or so, I can go. Or some will have episodes of syncope, So whenever, it happens quite frequently, they have this near syncope sensation or they have already syncopized. So that is very specific because if you do have a neuropathy and orthostatic hypotension, this will send you to a bucket of a very few types of neuropathy that can cause, orthostatic hypotension. And will help you in your diagnostic workup and treating the patient, But yes, again, I do believe that asking for autonomic symptoms is very important. But again, with a grain of salt that, for example, you can have patients with fibromyalgia, patients, with chronic fatigue syndrome, who will respond yes to a lot of your questions. And then it will be the frequency and also your exam and the testing that will help you out differentiating these disorders, because very important, fibromyalgia is not a small fiber neuropathy. Okay, so that's a very important concept that unfortunately in the literature is confusing, and especially because of the European, we can badmouth them here. I hope they don't hear, but they are the ones who create a lot of confusion regarding this.
Hypophosphatemia is often under-recognized, but the downstream consequences such as osteomalacia, fractures, and functional decline can be substantial. To our listeners, the single most important actionable message today is to check aphosphate. It's not on the typical chem panel, so you have to order it when the story fits.
I thought, to that point, that were they the ones who had done some studies that show that there's an increased incidence of small fiber neuropathy in the fibromyalgia population?
Yes. Yeah,
so this is more like a comorbidity, not a causative kind of thing.
Yeah, we can talk more, but the point is that, as you brought it up, is that a lot of times it will be very hard for you to differentiate clinically if they have, small fiber neuropathy, fibromyalgia. The most important thing, we haven't talked about exam yet, but is the exam. Because, it's a diagnostic criteria for small fiber neuropathy for you to have an abnormal sensory exam, and you must have decreased sensation for pinprick or temperature. Or if you have hyperalgesia, which is you just touch someone with a pinprick, they scream out, So, and it's not like they just say, oh yeah, it's a little painful. No, it's like you stick them, not you just go test the pinprick sensation, and they will scream out in pain or have a lot of pain. So that should be true, hyperalgesia. Or if they have allodynia, which is someone who has pain to non-painful stimuli. So you just go with your finger, and then the point that you mentioned, Galina, it's a specific complaint usually. If a patient complains to you that they cannot when they sleep, they cannot put any sheet on their feet, so the bed sheet can't touch their feet, is usually a specific symptom of neuropathy, because usually they have either hyperesthesia, which is they feel the touch stimulus more prominently, or they have allodynia, which is they will feel pain with any touch of that region, but usually when the allodynia is reproducible at the office, that is very specific that this is some kind of neuropathy going on.
So let's talk. We've kind of been dancing around it a little bit, but let's talk about the physical exam a little bit. So, a lot of people, both neurologists and non-neurologists, can sometimes get a little uncomfortable with aspects of the peripheral anatomy examination. So what are the things that you think are the most important and that you see most often done incorrectly?
Okay. Yeah, and especially we know that, the neurologic examination is not easy to do, and a lot of providers shy away from doing. So I think we could try to divide into motor, reflexes, and sensory for neuropathy, and also gait. I think gait is very important. So, and now, so as we are talking mostly to non-neurologists, I think that asking your patient to walk in your office, or outside the office in the corridor, I think it will give you a lot of information and why. So if they walk and they think that they're walking normally, that's great. So then, if they're walking normally, so you can say that most likely they don't have significant motor impairment. They most likely don't have significant imbalance, even though they may be complaining, but you don't see it. They're walking with a narrow base. They're turning okay. They are not almost falling on you, So you don't have to be a neurologist to say, oh, this is a stoppage gait. Oh, this is a sensory ataxia gait. No, you just walk. You see people in the streets walking. We as neurologists, we are always looking at people, walking and in the street all the time and diagnosing them. But but you don't have to be that. So just see them walk. If they walk normally, that shows you a lot that if the patient has a neuropathy, it's not a severe neuropathy. And also, after the gait exam, I always also have people walking on their heels and on their toes. That is more difficult for them. It's difficult to interpret. But I usually hold their hands for balance because I want to do that mostly for the strength. Because also tiptoes and heel walking, that is also balance into it, the old people. So then I ask them I hold their hand and I see how they walk, and they can give me a lot of information. So they can go high on their heels, and their feet off the ground and take a few steps. That's great. So the dorsiflexion of the ankles, and the foot are completely normal. So again, this is not a severe neuropathy. If they can walk on their tiptoes, like, they don't have to be like a ballerina. I joke and say, oh, let's see. Oh, I say, well, good ballerina, bad ballerina. I joke with them. But I ask them to walk on their toes. And if they can do that, kind of going high on their tiptoes and walk forward, this also means a lot to you that, there is no severe neuropathy going on. And I always also do tandem walking. Which again is also more difficult to interpret. But again, if you use the normal abnormal, can help you a lot. So if you have someone, a 60-year-old person who should be who should be able to walk 5-10 steps on heel toe walking or tandem walking, that also means to you say, oh, the balance of this person is completely normal. Okay, if they can tandem walk and they do not kind of step aside or fall, that you as a primary care doc, you could use that as a normal abnormal testing, and don't have to put that much of an emphasis on, if they took 1 step or 2 steps, that still may be normal, but you can just use as a specific evaluation to not having to refer someone, for neurology. So I think that can be helpful. And then I always ask them, the stance exam, I ask them to put their feet together, looking forward. I usually ask them to just lay their hands on their side, but you can also ask ask them to cross their hands on their chest and with the hands touching their shoulders, and then close their eyes with myself close to them, looking for the rhombic sign. And if they can stay with eyes closed for 20 seconds or so without stepping aside, that's usually also a sign that they do not have significant large fiber sensation loss. Talk about gait and stance, and then moving forward, the motor exam. So the motor exam, again, it's not easy to do, especially the way we do, and to check. But I think if you feel comfortable, so two very strong muscles. So the tibialis anterior, the muscle that lifts the foot off, that does dorsiflexion of the ankle, okay, or dorsiflexion of the foot, which is a kind of a complicated from anatomy to think about, but lift the foot off the ground, So tibialis anterior in the anterior leg, that muscle is very strong. So you should not be able to break anyone, even if it's an old person, without putting your weight on it. So I would recommend to people, for example, just come with your hand, like your finger. So you can even ask them with the sitting on the office couch or chair, and then you just come to their side, keep your heels on the ground, and then you put your foot off the ground. It should be able to do that. When they do that, you go with your hand and you push down. You can't put your weight on it because otherwise you may be able to break them. But you then got to push down and see if you have feel resistance, and you should not be able to break anyone. And this is very important. And also the plantar flexion, which is the tiptoe, is best examined with doing the tiptoe walking, because plantar flexion gastrocnemius is a very strong muscle to test. But if you check the ankle dorsiflexion only for neuropathy, it's already a lot. It's already, we're going to give a lot of information, because to test toe weakness, you need to be a neurologist, because you need to test with your index, and you go there and then you press. So, it's so easy to break like a toe flexion or extension with anyone. Of course, you again can use like, okay, if I cannot do that, this person is a kind of very strong bodybuilder. But I would recommend you not to test toe strength, because it's much harder. But foot dorsiflexion, and plantar flexion and the tiptoe walking, I think that can give you a lot of information again, because if you do not have ankle dorsiflexion weakness, you do not have a severe neuropathy.
As a quick aside, when we're kind of thinking about like muscle bulk as it relates to your findings on your strength exam, how often do you find that people have diminished muscle bulk before they have like a functional change in their strength exam findings?
Interesting question. I think for neuropathy, as the usual neuropathy will affect more the leg and the hand than the feet. Than the thighs, because it's hard, it's hard, I think, Michael, a lot of times for you to know, like, how they may tell you my legs usually to be much larger, or my muscle bulk. But I think on examination, I think when you see atrophy, I think atrophy will mean to you chronicity, and will mean to, for example, if you see someone who shows up to your office complaining only of bilateral foot drop, and then you look at their legs, they have very high arches, they have very ugly feet because the toes get very hammered, So, and then they have high arches, hammer toes. And they have thin legs, and they tell you that, yeah, my legs were used to be much larger than this, and now they're so thin. So, and then the thighs are usually still normal size. So usually, and they don't have pain. It'll be a motor predominant process. Usually going to be an inherited neuropathy, like a Charcot-Marie-Tooth disease, So I think looking for atrophy, hammer toes, and also high arches will help you with chronicity, and usually will suggest an inherited process. And usually will be people who have neuropathy for many years, but they may show up to you saying the neuropathy started 3 months ago, right? There is a good story of, Dr. Pinprick, who just passed away, I think last month, who founded our neuropathy center here and everything. So a neighbor of his, he had noticed it for many years. He had bilateral foot drop and had a stoppage gait. So he already suspected the neighbor had Charcot-Marie-Tooth disease. And then his neighbor shows up to his office a few years later telling him that the weakness started 3 months before. And they say, no, I know you're my neighbor. I've seen you walking for 5-6 years. You have this for a long time. So just to tell you that the patient perception of time also sometimes can be a little tricky. And that's why also we discuss it in the history that, we discuss it offline actually. So the best diagnostic tool for neuropathy will be time. So seeing your patient back will bring you so much information, because if this patient shows up to you with a 3-month history of symptoms, and you don't remember how he was doing, or he's a new patient to you, okay? Because if, of course, it's a patient of yours and you know them for like 10 years and this is very different, okay, sure, let's go ahead and pull the trigger on an investigation or referral. But if there's someone coming up to you that you don't know well with new symptoms, yeah, see them back in 2-3 months. Because if it's a kind of a rapidly progressive neuropathy, you see, or they will report to you like a few weeks later or a month later, say, hey, doc, I think you need to see me back again because this thing is worsening. Now I'm needing a cane. I wasn't needing a cane. Now I'm needing a walker or so. So I think that time is a great diagnostic tool for neuropathy.
It's so helpful to hear you talk about the elements of the exam that you would do, the motor testing, the gait. I didn't hear sensory testing, though. So let's put ourselves in the exam room of a PCP who, granted, may not have a tuning fork. I hear that all the time. So what can they do, without that? And let's say they have one. How would they use it? And how helpful is that? Is it important to document that at the time when they're first seen? You gave us a lot of information, how even just where the symptoms are, how the symptoms have come on, the chronicity. That's very helpful diagnostically. Other elements of the exam, I agree with you. I always do strength testing mostly to verify the severity and if there's a motor component. But let's just talk a little bit about the sensory testing.
Yeah, I think the sensory testing is I think reflexes are also important. If you feel skilled testing reflexes, I think if a patient of any type of age has a neuropathy and the ankle reflexes are present, you can also say they don't have a severe neuropathy, okay, of any age. So especially if they're older, because after 60, you can have absent ankle reflex and it can be normal. But I know that ankle reflexes are not easy to test, so then the reflexes, but again, you can use the normal abnormal rule. And whenever you think it's normal and present, that also reassures you that you're not dealing with something severe and sinister. But going to the sensory exam is very subjective. So then you have to tell the patient, I usually tell them to close their eyes and explain well what you're going to do. So I think if you do not have a tuning fork, I think that's kind of, we all have it, it's okay. So but using, I think, a cotton or a Kleenex, can be helpful to you. And also using either like a pinprick, a pinprick can be any kind of pin. You just go to your office and say, most of doctor office has something, they put there with a pin. Get that pin and examine the patient. Then you discard it, okay? Don't put it back. Don't put it back. That's not good practice. Just discard it, okay? Discard it after use. Then you ask the desk for more pins. But I think a pin. But this is the one is harder to find. But I love temperature sensation. I think temperature is more specific than pin. But let's do one by one. Let's first use the Kleenex. So usually I tell the patient, I go with my Kleenex very lightly, and I just touch their toes very lightly, and I say, hey. Oh, so now you tell me. So am I touching you? And I will touch with the Kleenex in the toe, in the big toe usually only. And then they'll say, yeah. And I say, where? Say, my toe. So if they can feel a very light Kleenex, or a cotton, I usually use more cotton ball. So if they can feel that, you can also again say, this patient does not have a severe neuropathy, okay? Because the light touch is either minimally affected or normal. Okay. So then if they do not feel the cotton, then I use my finger and then I touch them with my finger. If they also don't feel my finger, then I do pressure with my finger, okay, and see if they can feel. If they can't feel that, yeah, it's severe neuropathy, okay. If they should be able to feel your finger. If they can't feel when you use, kind of when you press with your finger, so that's the sign of usually a severe neuropathy. But that's the light touch. And light touch is usually not as sensitive as the other ones we're going to talk about now, which are pinprick and the temperature. So the pinprick, so usually I go with the pin, and then I touch them with the pin at the big toe, and I say, hey, can you feel I'm touching you? Okay. And if they feel, what I do is I do not ask normal or abnormal. I just say, can you feel? They can. And then I go with my pin climbing up the foot, going up the foot, up to the leg. And then I ask them, say, hey, do you feel the same all the way up? Okay. I try to ask specific questions. I do not say, hey, I do say, what do you feel? Do you think it's normal? It's not normal. Oh, because for the patient, it's so hard. And usually I also use specificity in my question. So I do not ask when I check, for example, the toe and the knee. I do not ask, do you feel less at the toe than the knee? Because they want to be nice to you to say, yes, I feel less at my toe than my knee. So I do the opposite. I use their niceness on my behalf and their behalf as well. So I go and say, okay, I touch the toe and the knee and I say, hey, do you feel the same on both sides? And and they will say yes or no. Usually I give value when they say, and the toe should feel more than the knee, okay? That should be the normal because of how we were innervated, how we evolved as a species. So because we have more skin receptors at the foot and at the hand than at the thigh and at the shoulders. And the face is where you feel the most, okay? So, but then I go with my pinprick, and then if they say that it's abnormal at the toe compared to the knee, I say, okay, so if you think the knee is normal, I do. If the knee is 100%, how much you give me at the toe, okay? And then if they give me like 95%, it's normal, okay? And another good pro as well is if they ask you to repeat, it's because it's normal, okay? Whenever they ask you to repeat, it's because the difference is so small that they are having ask you to do it again. So anyway, I don't remember a case that I trusted that it was truly abnormal because this is completely subjective. You don't know what the patient is feeling, so you have to try to be specific when you do it. So that's the pinprick, and then I usually go up, and neuropathy, the loss will be more at the feet than the leg, and I usually go up to where they feel normal. And I ask them, hey, where do you feel normal again? And then that's where, and usually it's going to be symmetric on both sides, okay, if they don't have anything on top of it. And that's light touch. The pinprick, light touch pinprick. And then, pinprick also, if they say they don't feel at all at the big toe, what I usually do is usually the pins have a dull kind of a head or they have a dull part of it. So I usually I ask them to tell me which one is the pin, which one is the dull part. And then I only say it's absent when they cannot differentiate both. And I feel that is helpful. Then temperature, I love temperature sensation because I think, it's, and I like more, I have this privilege of the office I work. We have kind of a thermistor, and we have a hot thing there, that you can use and test, like a hot sensation, heat sensation on the patient. But I think you can also use cold. You can get like an ice pack. Everyone has an ice pack, and you can use an ice pack. And I usually test the dorsum of the foot and compare it to the knee, okay, or to the lateral leg. And then you see if they feel it different, the coldness or the heat on both, and I do the same 100% type of thing. And why I say temperature, because I think temperature is more objective. So we are more used to feel as human beings temperature difference. That's why, you go take a shower, you put your hand or you put your foot. So anyway, we don't like to feel pain or pinprick. We usually are not well and well trained on differentiating those. So that's why I like temperature. I think temperature gives you a more specific exam. And if you do have neuropathy, you should have temperature sensation diminished at the toes and the feet, especially if you're thinking about a small fiber neuropathy, which, again, by definition, you should have an abnormal exam even before you do any kind of testing. So we can talk about when you go testing. I have a spiel on small fiber neuropathy to my fellows and everything, on how to proceed. So let's not jump there now. But and then if you do light touch and you do one of those, temperature or pinprick, I think you're doing great. It's much more than others. And remember, for the primary care docs, that the monofilament, 10 grams monofilament that you guys, some of you have and use for diabetic neuropathy, that is not that great for the diagnosis of diabetic neuropathy. So that is more, I know that people have studied that and that is a ways even, but to be honest, I think that this is more, just tells you more about, kind of the risk of developing ulcers and, and kind of the plantar protection of the foods we call, and they call, but so then I do not exam patients with a monofilament, okay? Because I feel that our exam is more sensitive, but a monofilament can be a tool you can use. And especially if you follow the protocols, they have a few, that you have like 5 spots in the foot that you should test and the way you should do it. But it makes things more complicated, at least in my opinion. I think if you just do just quick exam of the toes, it's going to be faster and easier, I feel.
What are your thoughts on the broken tongue depressors as your pin, quote unquote?
Oh, I think anything that can inflict some kind of pain, I think it's fine. Anything. I think creativity, it's great. I think, and I'm all down for anything that you can adapt. So, for example, in the hospital, Michael, I know you do a lot of hospital. So I have used like a Diet Pepsi can that just came and was kind of cold, and then I tested, with the Diet Pepsi can. I think you're just gonna be creative if you whatever you have available, not gonna harm the patient. Yeah, sure, do it.
I know I filled a exam glove up with ice water before.
See, yeah.
So I know we're moving into our proprioception and vibration. What's the relative benefits? Do we need to do both on every patient? What's your perspective on that?
Yeah, that's a good question. I think if you are not a neurologist, I think that because proprioception exam is not easy, So I do at least 4 modalities of sensation in all of my age because I'm a neuropathy doctor, So I do for a living, testing people's sensation. Yeah, that's what I do. So then I test in everyone vibration, eye touch, and temperature pinprick, and sometimes both. Okay, so 4 or 5 in almost everyone I see for neuropathy. But I think vibration. I think if you are not a neurologist and you do vibration, you're doing great. And you don't need to do proprioception. I think gonna be gonna put a lot of subjectivity and complexity on doing. And you may find it abnormal when it's not abnormal because you have to train the patient how to do. Because I don't know if you guys have thought about it, but who tests for proprioception, not neurologists, So I do that in my daughter. She loves it. She's 7-year-old. She loves to do the test of the toe. She asks, "Let's do it again, Dad. Let's do it again," because it's it's kind of fun, but no one does it. So people have 70 years old. No one has ever asked them to move their toe. So you have to stop to teach them how to do it, and be. But so then I think vibration is better. And then in vibration, how to do it. So you get your tuning fork. You can just slam that on the floor. Okay. So we have to have a good one because otherwise you're going to break it. Okay. Because you can also hit on your hand, but then to hit like you have to hit it, it's a lot. So your hand is going to be red and, kind of hurting after it. So you can just slam on the floor. And then you test it. So I know people have studied this on the seconds people feel and all that. I don't like that. I think that's very subjective. So what I usually do is I slam my tuning fork on the ground, and then I put out the toe. Say, "Hey, do you feel it?" And they say, "Yeah, I feel it." Okay. And then I take it out, and then I do it again and compare the toe and the knee. Okay. And then I say, "Hey, do you feel the same here and here?" And if they say no, I say, "Where did you feel more?" And they say, "Oh, the knee." And they say, "Okay, so if the knee is 100%, how much you give me at the toe?" And that's how I do it. And then I usually test, the big toe, the ankle, and the knee. So if the person tells me that the toe is normal, I do not do the ankle or the knee. And for the evaluation so in patients with posterior core myelopathy, they can have proprioception more affected than vibration, or sometimes both the same as equally affected. But for neuropathy, okay, you will essentially never see a patient that proprioception is more affected than vibration. So only doing vibration is completely fine.
Now, a quick word. I've had students show up with different frequencies of tuning fork on their rotations from time to time. What's the gospel truth here for what frequency we should be using?
Yeah, I think 128 or here in Mayo, we don't know anyway. I don't know. This one I even don't know why. I think it was Peter Dick. We use 165. You never find it. You can only buy if you go to specific websites, but the 128 to 165, I think you're fine. You should not use the 256 or the ones which are lower than 128.
Excellent. Great point. Any other special maneuvers that you might do during your exam that come up in edge cases or that you think that could be a quick and dirty addition for our primary care colleagues?
So we're talking about the ankle weakness. We're talking about the reflex. We're talking about the sensation. Yeah, we're talking about if they ask you to repeat, it's gonna be normal, and grade as normal.
That's a great one.
I think that whenever you also like look at their feet, this is obvious, but I think it's important to say. You look at their feet and they have like an ulcer or they have like a pain on it, like something because you just, oh my God, I found it. It's very, very specific. They have a severe neuropathy, okay? Because whenever people have ulcers in their feet, okay, that's I think a good point. Whenever they have ulcers in their feet, it's usually not only sensory dysfunction, okay? It's usually sensory together with autonomic because also the healing is affected, okay? So, for example, you guys may have seen patients with CIDP. They don't have ulcers in their feet. You may have seen patients with let me see other common neuropathy that you see nutritional neuropathy, alcohol neuropathy. You're not going to see ulcers in their feet. Alcohol nutritional, if they don't have diabetes, okay? Because diabetes not only affects the sensory nerve fibers, also affect the autonomic nerve fibers, and that will affect the tissue healing, okay? And and if you have a patient with an ulcer neuropathy, please send them to a neurologist, or if they have diabetes, it's usually going to be a poorly controlled diabetic, so you need to work with them on that. Or sometimes if you don't have diabetes, okay, that's a good pro. So if they don't have diabetes and they have ulcers in their feet and a neuropathy, long-standing neuropathy, this might be Charcot-Marie-Tooth disease because there is a specific genes that also they help with tissue healing. So there are specific forms of CMT or in some cases, there is a sensory CMT called hereditary sensory autonomic neuropathy. So that they may have very much of an increased risk of ulcers in the feet and amputations without having any other systemic cause. So the common question in the office is, they have this patient with a very healthy person and they keep having ulcers in their feet. It's so weird. And we can't find a cause of a neuropathy. We're looking for monoclonal proteins and all that, and even a nerve biopsy. Never do a nerve biopsy in these people because a nerve biopsy wound never gonna heal. Okay, they're gonna have a sepsis from it. Yeah, and that's an important point. So, but if you have ulcers in the feet and no diabetes and no other clear cause, it might be inherited.
So that brings us to a great question. So let's say we're some sort of neuropathy is in front of us, whether it's small fiber, mixed fiber, large fiber maybe. What kind of testing do we need to do after we've kind of seen them, taken the story, gotten an exam? What kind of testing do we have in common between these different types of neuropathy that are kind of like good to do across the board?
Okay, so I think that and you can say mixed large and small fiber because most of neuropathies are mixed large and small fiber, okay? Very rarely neuropathies only affect the large fibers. Very rarely only affect the small fibers, So isolated small fiber neuropathy is rare. So we did a study here, and I wasn't on staff yet, but some of my colleagues did a study here in Olmsted County, Minnesota, and they found that isolated small fiber neuropathy, which means people with paresthesias or pain in the feet, abnormal sensory exam, and a confirmatory test, okay? Either quantitative pseudomotor test or QST or skin biopsy, okay? Confirming the small fiber dysfunction and normal EMG, normal nerve conduction studies. So to be called isolated small fiber neuropathy or true small fiber neuropathy, you should have a normal EMG. That is rare. It's rarer than CIGP, okay? So CIGP incidence in Olmsted County is 1.6 per 100,000. Of small fiber neuropathy is 1.3. So it's anyway, but some people think it's very common, usually the patients will also have the large fibers affected, which it should be, So then what tests to do? So I think, a blood workup is the most important for any kind of neuropathy. I think that I don't know, it's hard, I think, for a primary care provider, non-neurologist, to phenotype a neuropathy. I have posts on it, just a little bit of a propaganda here on my thing, but it's not easy, okay? It's not easy. So I think that whenever a patient has like ankle weakness, whenever they have an abnormal gait, whenever they have the falls and neuropathy, they should be seen by a specialist, okay? And as you send them for a specialist, you also should send them for an EMG, okay? So an EMG is only helpful in situations where, I think you must refer your patient as a primary care doctor because they have diabetes and you examine them, they have some neuropathy. So why do an EMG on them? Oh, for baseline? You have your exam for baseline. You don't have to order an EMG for that. There is a lot of literature on this, and I do not recommend EMGs for those that the cause of neuropathy is obvious. For example, you have someone who started eating peanut butter. Okay, this is a real case. The person decided to went vegan, and they went vegan, but they also were only eating peanut butter, nothing else, peanut butter and water. Like it was anyway, poor person. It wasn't a smart decision. This person developed a horrible, painful sensory neuropathy. Okay, it was a nutritional neuropathy because peanut butter doesn't have all the nutrients you need for your life. This person didn't know that. So then, in this person, do they need an EMG? No, they don't. It's kind of you do, of course, the blood work we're going to talk about here. Do you check for vitamins and you're going to replace the vitamins and tell them to change the diet, please. But do they need an EMG? I don't think you need an EMG. It depends a lot where you are and in your practice. But I think for the primary care docs and non-neurologists, I think you only need an EMG if you are referring them to someone, to be honest. I don't think you should wait the EMG results to refer to someone. And why? Because depends on who's going to do your EMG. Some neurophysiologists, they exaggerate when they're reporting severity of neuropathy. I also have posted about it. So if someone rely on a lower limb study only EMG to call someone having a severe neuropathy, okay? So that's an important point. So if you think it's a bad neuropathy, do upper and lower limb. And why? Because if the upper limb conductions are normal or near normal, this is not a severe neuropathy. Okay. And again, so been going back to the primary care doc. So what kind of blood work to do? I think you should check, a CBC. You should check, I usually do a comprehensive metabolic panel because I also want to see the liver enzymes. Because if the liver enzymes are normal, this is not hepatitis. Okay. If the kidney dysfunction is normal, creatinine, all that is normal, this is not chronic kidney disease. So, and then you do a CBC because, you may, once in a blue moon, you may see someone with Palm syndrome, or something very like a unicorn may show up to your office because unicorns live, they exist. And then you see like a marked normal CBC. Okay, sure, hematology or something, very profound anemia. So, you can have macrocytosis, and then you're going to do your B12, and then you're going to find out, so this is B12 deficiency. So a CBC, metabolic panel, you also, because also sometimes, the metabolic panel also going to help you. For example, you have a very low BUN, this person, for example, from like malnutrition, for example. So I think this basic tests help you a lot. And then I always do B12, folate, and B1 and B6 on people. And why I do that? And I also do copper, because maybe copper they may not need, but I do copper and zinc. And why I do that? Because I feel that zinc is a great one for nutrition. So, because usually, this is, of course, never take that, fully from a peripheral of neurology about nutrition. But if you have a normal zinc, you're probably not malnourished, okay, to the point of just the malnutrition cause your neuropathy. But anyway, so again, B12, B1, which is thiamine, copper, zinc, and B6. And why B6? Because people take supplements. They don't tell you. They take just supplements. They buy online. I always tell my patients, never buy multivitamin online. Never. Go to Costco, Walmart, Walgreens. Buy the off-the-shelf ones, cheap ones, okay? Because the super vegan, whatever, they always come sometimes with a lot of vitamins, and then they can harm the patient because it's hypervitaminosis of B6 can cause neuropathy, and a bad one, a sensory ganglionopathy. Okay, so that's what I usually do. It's basic workup, and I don't think that any primary care doc need to do. If you're not referring a patient for neurology with a severe neuropathy, you don't need to do SPAP or immunofixation. And why I say that? I say because all these monoclonal associated neuropathies, amyloidosis, POM syndrome, IgM-associated neuropathy, they're all severe neuropathy. They're all progressive, okay? So if you're not referring your patient to a neurologist, I don't think you need to look for an MGUS because you're not going to know how to interpret, and then you're going to refer to hematology who will not like this referral, because they don't like to see MGUS. And I know that well because I know them. So I don't think you should. So if you do a basic metabolic panel, as I told you, CBC and the vitamins, and also, of course, check A1C, and also check a lipid panel, okay? That's an important point, lipid panel, and why? There is growing evidence, especially coming from my friends from the University of Michigan, Brian Callahan, Melissa Lafros, Dr. Eva Feldman, that obesity, okay, hyperlipidemia, is associated with neuropathy, especially in type 2 diabetics. So they can even make the neuropathy progress faster. So tell your patients to eat healthier, exercise. Even there is a person there, Stephanie, who does research in mice. So then she kind of put them to exercise and change their diet and all these things. And she has shown improvement of neuropathy in these mice. They're doing trials now there with bariatric surgery, also GLP-1 and all that, but improve your metabolism, may also help you out with your neuropathy.
Excellent. That's a ton of information. And, we've been kind of splitting these into two-parters as far as like assessment and diagnosis, and then a second part on treatment. So we're going to have to ask you, can we have you back at some point in the future to talk about some treatment management type strategies?
No, that would be great. Yeah, because
Awesome.
I think, we do. I think neuropathy, there is a lot of education, you need to educate your patients, so you have to tell them a lot of things, and it's a lot of perspectives, and the patient needs to understand, because they can get very frustrated, because neuropathy, I learned that in my fellowship, that a lot of neuropathy management is patient coping with it, so they need to understand well what you're saying, and so it'll be a pleasure. Yeah, let's schedule the next one.
Yeah, and I know as a quick plug for Marcus's channel, I've learned a lot of stuff. That's on X at Marcus V Pinto. I really enjoyed the one, especially, right? The kind of the number we always quote, 1 out of 5 cases end up being idiopathic, but with a little more leg work and skull sweat, you can sometimes get that number even lower. So very interesting stuff. I'm not going to go into that because that gets a little more esoteric, but yeah, great online education to be found on Marcus's profile.
Marcus, thanks so much for joining us today. And I feel like we got a little window into what it's like to be one of your fellows and just dropping knowledge right and left. Thank you so much for those tips, pearls. I can just imagine you, bending on your it's bending on a knee and putting a cotton ball against the toes and kind of revealing truth. So thank you so much for joining us. And I can't wait for part 2. I couldn't agree with you more that the management depends so much on a partnership around education and really like prognostication, kind of talking about prognosis and love. Just want to underscore that tincture, time is kind of part of our diagnostic process. So thanks again for those tips.
My pleasure. Yeah, it'll be an honor to come back here. And one of my goals, and that's why I do this channel, I put politics aside, okay, because I use my Twitter as my neuropathy blog. I put everything aside, and I try to help people, because only at my office I won't be able to help as much as I want. So it's my pleasure to be here, and it'll be a pleasure to come back.
Awesome. Well, thank you everybody for listening, and make sure to tune in next time as we talk more about neuropathy management. And you can always find our stuff at the neurotransmitters.com, and we are also on X at neuro_podcast. Thank you both again, and we'll talk again real soon.
Goodbye.
Bye.